This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. He is a 5-year-old kid and he doesn't see much, probably since birth. And he has not had an eye consultation by his parents. I don't know for what reason, maybe for ignorance or lack of funds or not just the will. And he has got these dense white cataracts and there's also nystagmus, suggesting that this could be there since his birth as well. Well, it's a sad state of affairs, but the child was very active and very happy. And it was a challenge for me to operate on this case. The biometry was going to be very difficult. The child was not cooperative at all. Of course, we couldn't do optical biometry in this patient, and under IV sedation, we did immersion A-scan biometry. These are the biometry readings, and let's see how the surgery goes. The surgery is being done under IV sedation and supplemented by some form of posterior subcutaneous anesthesia. The cataract is hypermature, and I expect fluid to come out as soon as I puncture the capsule. Side ports are created. The anterior capsule is stained and dispersive OVD is placed inside the eye. In these cases, the real challenge is performing the anterior capsulorhexis as well as the posterior capsulorhexis. Dealing with the nucleus and the lens matter is not at all an issue. As soon as I puncture the anterior capsule, the liquid lens matter just flows out. So I come out, I'm just trying to irrigate out the anterior chamber so that the visibility increases. At the same time, the liquid lens matter inside the bag also is getting evacuated. There is no nucleus to be seen. And once the capsular bag is divided of all the fluid, I'm inflating it with the OVD. Time to perform the rhexis. I'm aiming for a 5mm central rhexis. I'm using the Dr. Haldipoker forceps to perform the same. This being a long-standing cataract, the capsule is behaving differently. As we are all aware, the capsules in these young patients are going to be very elastic, and care has to be taken that we don't end up having a rhexis larger than what we intend to have. So pulling it centrally always helps, and the rhexis is done now, and I think that the size is appropriate. The remaining lens matter and some of the cortex is just evacuated out. Now time to perform the posterior capsulorhexis. The chamber is inflated with cohesive OVD. I'm using sodium hyaluronate. The globe is being stabilized to ensure that I can get as much of a red glow as possible. The posterior capsule is punctured with a bent 26 number needle. The flap is held and I'm trying to perform the posterior capsulorhexis. As I reach these areas, the capsule starts to wrinkle a lot and it looks like tearing is going to be difficult simply because of the nature of the capsule. The capsule is not healthy owing to the long-standing nature of the cataract. So I'm finding it very difficult to tear at it. This is the stage at which I realized that tearing could become uncontrolled, hence I aborted the idea of performing the posterior capsulorhexis with the forceps, and I was not feeling that I had enough control on the tearing. So I decided to use the Vitrector instead to perform the posterior capsulotomy. I begin by doing a limited anterior Vitrectomy and then simultaneously labeling at the posterior capsular margins. Gradually, the opening of the posterior capsule is enlarged. Simultaneously, I'm also doing the anterior vitrectomy. These are the settings which I'm using to perform the capsulotomy, the same settings as I'm using to do the anterior vitrectomy. Slowly and steadily, the opening of the posterior capsule is enlarged. So I'm aiming about 3.5 to 4 mm opening of the posterior capsule. I feel now the anterior vitrectomy is adequate. Now is the time to confirm that I'm not missed out on any vitreous fibrils, so I'm just using diluted triamcinolone acetate just a little bit to stain and see. Looks to be alright. Now is the time to implant the lens. I'm going in with a single piece lens here, but before that, the bag is inflated with sodium hyaluronate. Once the vitrectomy has been done, the eye becomes extremely soft. And to add on, these children will have extremely low scleral rigidity. So there's a lot of tendency for the chamber to collapse because of these two factors. One is the anterior vitrectomy, the eye would have become soft, and also because of the low scleral rigidity. Manipulating the cartridge into the incision becomes a little bit tricky, and I'm supporting the eye with an instrument through the side port. Gently, the hydrophobic lens is released into the bag. The distal haptic is nudged into the bag, followed by the trailing haptic. Once the lens is in the bag, now I can see that the posterior capsule margin has become a little bit distorted. This is giving me some suspicion that maybe some of the vitreous fibers have got stuck in, which is causing this distortion of the posterior capsulorhexis margin. So I just lift up the lens and then go behind the lens with the vitrectomy cutter and then proceed to do a limited anterior vitrectomy. And as it is being done, I can see that the margin of it has become regular, suggesting that everything is alright now. The ovary in front of the lens is then removed. Time to close. Because of the low scleral rigidity in these children, the eye would become extremely soft, and that's the reason I prefer to suture the incision. Air bubble is put inside the eye, and I'm using a 10-0 Vicryl to suture the wound. Care has to be taken that the suture has to be partial thickness. We don't want a full thickness one. I'm ensuring that adequate width of both the corneal and the scleral tissue are taken in the suture bite, and then the knot is buried. This is an absorbable suture and I don't have to remove this. The side ports are hydrated. That's it, the case is done. Let's see how things turn out the next day. To summarize, the more challenging aspect of managing this hypermature cataract in this young child was dealing with these capsules. They were not healthy. Fortunately, the anterior capsulorhexis could be performed with the forceps itself, whereas the posterior capsulorhexis was not easy with the forceps as it was inducing some traction to the other parts of the bag, and also it was not seeming very controlled. Hence, I resorted to the Vitrector assisted posterior capsulorhexis. We can see the edges are alright, and they give a reasonable amount of strength. And the same instant, obviously, we are going to perform the anterior vitrectomy. So pediatric cataract surgery is not difficult at all. The only two important things are to perform the well-centered anterior capsulorhexis as well as the posterior capsulorhexis. And of course, in children less than 5 years, I prefer to do a limited anterior vitrectomy along with the posterior capsulorhexis. That was it. Thank you for watching and hope you found this helpful.